Okay, moving on. Our next speaker is Melinda Irwin from Yale. Melinda's talk is entitled Influence of Weight Management and Physical Activity on Other Outcomes Such as Comorbidity, Physical Function, and Quality of Life. Melinda?
Good morning. Thank you again to the program committee for inviting me here to talk about other outcomes associated with weight management and exercise after a cancer diagnosis. Okay, so there's a number of outcomes. I'm going to try to be as succinct but conclusive as I can. As you can see, there's about 10 or so different outcomes that have been examined in relation to weight management and exercise. Some have been studied more than others. So first we're going to talk about quality of life. Most studies, and these are, I'm going to focus on all interventions, so not the observational research that's been done, but the weight loss or weight management or diet interventions and exercise interventions. And most of these studies, when they measure quality of life, it refers to the physical, emotional, mental, and social well-being. And this is often captured via self-report. Common questionnaires are the SF-36, which is nice to use because you can also compare it then to non-cancer populations. And then the FACT surveys, the Functional Assessment of Cancer Therapy surveys, and they have a number of different subscales, one related to general quality of life and then some specific to different cancers. Oftentimes, the interventions that are done during treatment are more about attenuating adverse changes in quality of life, so how exercise may attenuate the decrease in quality of life, compared to interventions that are post-treatment that seek to speed recovery and improve quality of life. Now, these interventions may not improve all aspects of quality of life. It may be that there's an improvement in physical quality of life, but not the mental aspect of quality of life. And most importantly, there might be concerns with attention effect. What that means is it the intervention, let's say exercise, that's actually improving quality of life, or is it the attention given to the participants enrolled in the study? So few studies have really matched or controlled for the attention given to the control group and the intervention group, making sure there's similar attention. And then a number of studies have had an issue with ceiling effect, where they're enrolling individuals who already have a high quality of life, so it impairs the ability to see an improvement in quality of life when they already have a good quality of life at baseline. What about cancer-related fatigue? We know that this is one of the most commonly reported symptoms in cancer survivors, and it's a distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness that is not proportional to recent activity, and it often interferes with usual functioning. Exercise may improve fatigue, and most of the studies have looked at an improvement with fitness being the mediator towards improved fatigue levels. However, similar to quality of life with the ceiling effect, few studies have actually enrolled or targeted individuals who actually have cancer-related fatigue at baseline. So many have just, maybe the primary aim of the study was not fatigue, but something else, and they might not see as strong of an improvement in fatigue as they would if they targeted those with cancer-related fatigue. So what about the studies, the interventions? A lot of, in regards to exercise, there was an important publication led by Katie Schmitz with ACSM and ACS looking at the literature of 85 exercise trials, and this was published in 2009. So all the trials prior to 2009 looking at exercise in a number of different cancers during treatment and post-treatment. And overall, there was a favorable effect of exercise on quality of life, physical function and fatigue, muscular strength. However, most studies were done in breast cancer patients. And of note is the fact that while we still think of this field in its infancy, especially in regards to cardiovascular disease and cardiac rehab programs with exercise, the first paper published of exercise and intervention was actually published in 1989. So we still have a lot to go in this body of research, but there were studies, important studies done dating back to 1989. A recent meta-analysis of 34 trials that was published by Lauriane Bouffer showed that overall, with exercise interventions on quality of life, showed an overwhelming, as you can see, most of them show a benefit of exercise on quality of life. There's some variability with the confidence interval crossing 1, and once again, that could be due to the ceiling effect. But most of the studies show a benefit of exercise, and these were done, examined during treatment versus post-treatment, a number of different cancers, and there was no effect modification by cancer type or during or post-treatment. So in summary from this large meta-analysis, was that while the effect size was small, there was consistent evidence to support implementation of exercise as part of cancer care, and that the results were comparable across different subgroups. So similarly with cancer-related fatigue, now this is a meta-analysis just with breast cancer treatment, but similar findings have been observed in prostate cancer and a couple other cancers. And in this meta-analysis, we see, once again, an improvement in fatigue, a lowering of fatigue with exercise during and post-treatment. The studies at the top of this forest plot are during active treatment, and on the bottom is after treatment. This meta-analysis actually showed an improvement of exercise on fatigue during treatment more so than post-treatment. That could be related more so to that fatigue is more common during treatment, during chemotherapy, than post-chemotherapy. Other studies, though, have seen a benefit of exercise after treatment on fatigue. So while it's important to show some of the meta-analyses, it's also important to dig deeper and examine some of the studies that have been really important and seminal in moving the field forward. And most of those have been done by Kerry Cornea. He did some of the earlier trials, the first being the rehab trial, which was in postmenopausal breast cancer survivors after treatment, after chemotherapy and radiation therapy. And he showed that exercise improved quality of life by about 8%, and that an improvement in fitness mediated the effect of exercise on quality of life. And so it could be, is it related to, is vigorous intensity more important than moderate intensity for quality of life? That might be the case, as well as fatigue. He then followed up that with the START trial, which he just mentioned earlier in regards to the breast cancer outcomes. But in this trial that was during chemotherapy compared to the rehab, which was post-treatment, and this was one of the largest trials of 242 women during chemotherapy, and it compared aerobic exercise and resistance to usual care. Unfortunately, no effect was observed on quality of life or fitness, but there was an improvement in self-esteem, fitness, body composition, and most important was chemotherapy completion rate. So this was one of the first studies, not with the primary endpoint of looking at chemotherapy completion rate. Nonetheless, though, they did find that the exercise groups had an improvement in chemotherapy completion rate compared to the control groups. So that's sort of another endpoint where exercise or weight management interventions may be important, another outcome being chemotherapy completion rate. So why did exercise not improve quality of life or fatigue during treatment? It could be that their measure of fatigue and quality of life was a little bit different than some of the other studies. It could be the amount of exercise during treatment was insufficient, or it could be that the declines in quality of life and fatigue that occur where exercise attenuated it, but not enough to statistically significant effects. They then followed this up with the CARE trial and a large sample of 300 women during chemo. This study didn't have a control group per se, but was looking at different doses of exercise. So the recommended amount of exercise of about 2.5 hours per week of a moderate intensity compared to a high intense, 60 minutes per week, and then a 60 minutes per week of aerobic and resistance. And the top bar here, the black lines, are the 60 minutes per session of aerobic exercise that had the strongest benefit on attenuating adverse changes on the top is the physical functioning bar, and on the lower graph here is the physical component score of the SF-36. So, and the bottom chart here actually found a significant improvement of that 60 minutes per session of aerobic exercise on attenuating the decrease. There's no usual care group in this study, so it's not concluding that this isn't better than usual care, but looking at different types and durations of exercise. So the take home from this was that more exercise is not harmful, but actually might be a little bit associated with better less decline in these adverse endpoints, physical functioning and fatigue. So one of his earlier studies looking at chemotherapy completion rate has recently been looked at by another group out of Europe, where they did another large trial, about 230 breast cancer patients during chemotherapy, and they had usual care, a home-based group called OncoMove versus a supervised exercise group called OnTrack. And the top here you see that the supervised exercise group, only about 12% had dose adjustments to their chemotherapy, compared to 34% of participants needing dose adjustments in the usual care group or the home-based exercise. However, at the bottom here, both exercise intervention groups had only about a 10% dose reduction compared to a 25% dose reduction in usual care. So exercise could be very important during chemo in assisting women and men undergoing chemotherapy with completing their chemotherapy. So those were exercise interventions, but what about the combination of diet and exercise or weight management on physical functioning, quality of life, and fatigue? So Wendy DeMarc-Wanfried has done some of those studies. Her first one really looking at the RENEW trial, which was a mixed group of older breast, prostate, and colorectal cancer survivors, a large sample size of over 600. And importantly, this was not a supervised intervention, but a telephone and mail-based intervention. And this study showed a nice improvement of the intervention on the primary outcome of physical function measured via the SF-36. So while both groups had a decline in physical function, there was an attenuated decline in the intervention group. And then also an improvement in quality of life, general health quality of life measured via the SF-36. And this is really important in that it was older individuals, and functional independence is critical for this population. And so showing that exercise and healthy eating and weight management can keep them as independent long-term as they age is a really important finding, especially given it was all telephone and mail-based as well. So more recently, the ENERGY trial, which is a larger weight loss trial in women with breast cancer post-treatment, about over 600 women who had completed treatment for breast cancer. And this also is a 2-year group intervention, but then followed up with telephone-based intervention. And they also looked at quality of life and physical function outcomes. There were, as you can see in the figure at the top, there were transitory improvements in physical functioning over time. The black line is the intervention group, which was a weight loss, healthy eating, and exercise. So sort of an attenuation of a decline of physical functioning over 2 years. And then in the bottom with vitality here, you see also this kind of an improvement during the intervention, but not necessarily sustained long term. So I think more research needs to be done to look at the long-term effects of these interventions after they have completed, but following up participants longer term. So oftentimes most of the research that looks at exercise might be an aerobic exercise or resistance training intervention, but there's a growing popularity with yoga interventions. Julie Bauer has done some interesting yoga interventions looking at cancer-related fatigue and looked at inflammatory biomarkers as a mechanism of how fatigue might be improved with yoga. And she showed here in this finding the black bars again being in this case, the white dots are the yoga groups showing an improvement in fatigue compared to an education usual care group, as well as an improvement in vigor. So this was a small sample size, but showing that giving participants options of different types of exercise might be just as important. So they might adhere to exercise if it's a type that they prefer to do. So as mentioned earlier, a lot of the research today has been done in breast cancer populations. So we just recently completed a study in ovarian cancer, women who were originally enrolled having completed their first rounds of chemotherapy, and then looked at how a home-based telephone-administered physical activity intervention may improve quality of life and fatigue. And what's important about studying ovarian cancer patient population is, unfortunately, 75% may recur or die within 2 years of their diagnosis. So we actually showed the second bullet here that their baseline quality of life and fatigue measured via the SF-36 was worse than compared to healthy women and breast cancer survivors, and that the effect of exercise on quality of life and fatigue were stronger among those who had worse quality of life and fatigue at baseline. Overall, though, we showed that exercise improved quality of life, where there was this continued decline in the control group, and that it also improved fatigue in the exercise intervention. There were about a third that experienced a recurrence during the intervention, and unfortunately, the intervention was not able to improve quality of life or fatigue among those third that actually had a recurrence. So we do need to study cancers where those with metastatic disease and or a higher disease stage, and the benefit of exercise and weight management in that population. So other cancers, Jen Ligabell and I recently, it's going ahead, completed an evaluation of the Live Strong at the YMCA exercise program, which is a program offered throughout the country. It's group-based with about 10 participants, cancer survivors, any different type of diagnosis. And it's a 3-month, twice a week, or 24-session program. We evaluated this program and showed that the Live Strong program was associated with improvements in quality of life and fatigue, and that it seemed dose-dependent, that those who had higher attendance to the program had greater improvements in quality of life and fatigue compared to those less attendant. So switching now to some of the other outcomes related to cancer, one being body composition. Pam Goodwin talked about weight and weight gain being common after diagnosis, but fewer studies have actually looked at bone loss. The top chart here shows changes in bone and lumbar spine with different treatments. So normal menopause versus tamoxifen, ADT or AIs. And so what is the role of exercise or weight management in attenuating adverse changes in bone loss or preventing any bone loss? We know that chemotherapy and endocrine therapy can have even more adverse effects on these on bone endpoints. So there's actually been, when we first just talk about weight loss trials for cancer survivors, given that weight gain is common, there's been 3 large trials looking at weight loss being feasible and of about a 5% to 6% change with these year-long or 2-year-long interventions. A really important study by Christy Before looking at rural health and how to enroll participants who live in rural areas, but showing similar, if not greater, amounts of weight loss with group telephone conferencing. So these are important studies, but equally important, as Carrie mentioned, is looking at body composition. Also, I forgot about this slide. So this also looked about telephone versus in-person, showing that telephone is as effective as in-person in weight loss, which is important for whether you're studying a rural community or nationally wanting to roll out interventions on cancer outcomes, that the telephone can be as effective as in-person weight loss counseling. But switching now to talking about bone density, there have been very few trials actually published looking at exercise or weight management on bone endpoints. This one study is the largest to date looking at exercise, and as you can see, there's adverse changes in bone mineral density, but exercise attenuated that decrease. But there's been few studies done, some by Carrie Winter Stone looking at this in prostate cancer, but more research really needs to look at the bone endpoints, especially in patients at diagnosis before chemotherapy, following them through that time point, and then also among those maybe taking AIs or ADT and how exercise may improve those endpoints. Now switching to lymphedema, Katie Schmitz has done some of the landmark studies looking at how exercise, in this case resistance strength training, doesn't have an adverse effect on lymphedema, but actually can be associated with less exacerbation among those with breast cancer-related lymphedema. This study has been followed up with some other studies showing consistent effects of strength training on preventing and or not exacerbating symptoms. Her other publication in preventing lymphedema also showed a benefit of exercise on preventing lymphedema. Another endpoint that's common with a cancer diagnosis or treatment is sleep. There's been not a lot of papers published on the role of exercise or weight management with sleep. Karen Mustian did an analysis looking at yoga intervention on sleep outcomes. And the blue bars here are the yoga intervention compared to yellow, the control group. And when you measure sleep by a number of different measures, you see that overall the yoga intervention improved sleep outcomes compared to control. What about joint pain that is common with AIs, also called arthralgias? We did a trial of looking at how to treat AI-associated joint pain, and we showed that the exercise intervention, this year-long program of resistance and aerobic exercise, decreased joint pain compared to the control group. This was an important finding in that it might improve AI adherence, which we know can be a problem among women taking AIs. This study was a treatment intervention looking at how to improve the joint pain, so future studies looking at how to prevent this common side effect is important and should be done as well. And so getting to the last two topics of outcomes, one that's really important that's been understudied is comorbidities. So this analysis from the energy weight loss trial recently published showed that the intervention group of exercise and healthy eating was associated with a fewer incidence of comorbidities compared to the control group, about half of the number of new comorbidities. So this is really important to follow up on, since there's few studies looking at comorbidities, and we know, especially in breast cancer, that most might have cardiovascular outcomes rather than a breast cancer outcome. Lee Jones has done a lot of the research looking at cardiovascular disease, in this case in breast cancer survivors. This cohort study recently published showed that those with higher physical activity levels, if you look at the bottom row here, and going across, those with higher physical activity levels have about a 35% lower risk of dying of cardiovascular disease. This is in a breast cancer cohort. So exercise is important not only for cancer outcomes, but also for the cardiovascular disease endpoints. And one measure, while we can't always do these large trials with cardiovascular disease as the endpoint, but we could look at cardiorespiratory fitness or VO2 max as a predictor of mortality. And we know that to maintain full and independent living, a low VO2 max or VO2 max greater than 15 or 18 is important. So there could be studies where you measure this at baseline and see how you improve their fitness level as a marker of improving mortality. Unfortunately, cancer survivors have lower fitness levels than those without cancer, and most exercise trials have been able to show an improvement. These are normative values. When we look at on the right here, the healthy sedentary women control group have a higher VO2 max than women with breast cancer, and that is also shown here on the other figure. And meta-analyses published by Lee Jones also showed that these short and long-term exercise interventions are able to improve VO2 max over 3, 6 months, or a year long, and that this is feasible during treatment and post-treatment, where we see about a 5 to 15% improvement in VO2 max. So my last slide here, cognitive function has been significantly understudied. There are a lot of studies in progress right now of how exercise or weight management may improve cognitive function. This is just a cross-sectional study by Sherry Hartman. She does have a trial in progress right now, but there's been no papers published of exercise or weight management interventions. But this is showing those who are physically active versus not active in improvement or better cognitive function. So this really needs to be followed up. There are a number of studies in progress, though, so that's good to know. And one yoga intervention showing that, the red bar here, the yoga intervention showing an improvement in cognitive problems over time. So in summary, there's limitations of the studies to date. Most studies have been done in breast cancer, most enrolling healthy patients without side effects, few controlling for the attention effect, few in metastatic patients. limited studies in bone mineral density, cognitive function, and peripheral neuropathy. And then very few interventions are looking at the combination of these lifestyle interventions with medications and how lifestyle intervention may improve the toxicities or the side effects of medication, and that might be another important mechanism for improving cancer outcomes. Promising studies in older patients, rural communities, and racial ethnic minorities. And then a growing number of studies. There's a lot being published now looking at different modes of delivering these interventions. So in summary, I think there's strong evidence that exercise and weight management improves quality of life, fatigue, fitness, body weight, lymphedema, sleep, and joint pain. But there's uncertain effects of exercise and weight management on bone mineral density, cognitive function, peripheral neuropathy, and CVD biomarkers. So also more studies needed in individuals with treatment-related symptoms or higher risk groups. And more studies needed of lifestyle interventions on adjuvant treatment adherence and efficacy of those treatments, and in combination with cancer therapies to attenuate toxicity. Thank you.